Welcome to This Week in Health IT. It's Tuesday Newsday, where we look at the news which will impact health IT. Today, we're going to talk about a lot of stories. We're going to do a gaggle of telehealth stories. We're going to take a look at what's going on with cybersecurity. Since we have my friend Drex DeFord in the house, we always talk a little cybersecurity. $1.2 million paid out by UCSF should be an interesting story. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. We're working on something called Clip Notes, which I am still not allowed to talk to you about, but we are excited about it. The first one will be this Friday, and it's designed for you to make it easier for you to consume and share this content. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. We closed out the COVID series on July 1st, and we are excited to announce that Sirius will be a weekly sponsor of This Week in Health IT through the end of the year. Special thanks to Sirius for supporting the development of the next generation of health IT leaders. If you haven't signed up yet for 3X Drex, you are missing out. Text Drex, D-R-E-X, to 484848 and receive 3 texts every week with the stories that you need to know to help you stay current. This is a service of Drex DeFord, our guest host for today's show. Good morning, Drex. Welcome to the show.
Thanks. I appreciate it. It's good to be here. It's always good to be here with you.
Yeah. Well, I'm looking forward to the conversation. It's, the last couple of times was really I'm not sure. We ended our COVID series, but I want to make it clear to people. It's not that we believe that COVID is beyond us or past us. We buttoned up that series and put it in the archive. There's a lot of great stuff for people as they're scaling up and preparing and those kind of things. But we feel like we've collected enough of that information for what health IT should do and be prepared to do. And now we're going to sort of go on to really exploring some of the other things that, some of the other topics that we didn't explore as much during the COVID series, like, infrastructure and operations, interoperability, 21st century cures. I mean, there's so much to talk about in healthcare. It doesn't all stand still. It all still progresses forward. But It's great to have you back on the show. What have you been up to?
Man, I'm just working on a bunch of different stuff. Obviously, I have I don't know can I say their name? CI Security. I just did. I have a client that I'm doing a bunch of work with, and we're actually working right now on what I think is going to be a pretty interesting and kind of maybe a little bit of a head-scratching report on the data in the wall of shame over the last 18 months and the trends that have been kind of going on there. So I'm working on that right now, and I think we'll probably have that out in the next couple of weeks, and happy to share it as soon as I get it done. One of the other weird things that I've been working on that I've kind of just not been spending a lot of time on, but I sort of bounce back and forth between regular work and this. So we have the top 30 under 30. You see those lists all the time, that kind of stuff.
Yep.
So I'm working on, I don't know exactly what it'll turn into, but the top 50 over 50.
Great. It's a great list.
So I'm thinking about, and the beauty of it is, since it's mine, you don't necessarily have to totally be over 50. There might be a couple of squeakers that get in there, and there may be more than 50. But it's a good little kind of way to think about it anyway. So if you've got suggestions about somebody over 50 who's in health IT who you think has been like a real leader in the business, feel free to drop me a note. It's easy. Drex at drex.io. I'm happy to take nominations.
Drex at drex.io. I'll give that a thought. There might be some people who don't want to disclose that they're over 50, just for clarity.
That's true. That's right. I know that's true.
All right. So there's there's a lot of news. I'm going to kick us off. There's a gaggle of telehealth stories, has been the case. So we're going to continue to parse these for everybody and see where it takes us. So there's a healthcare finance news story. 340 organizations tell Congress to make telehealth permanent. Providers to Congress, patients will lose access to care without permanent expansion of telehealth. That's Fierce Healthcare. Hundreds of industry groups call on Congress to advance permanent telehealth reform, healthcare IT news, and senators call for CMS to provide plan for telehealth changes. And by the way, that's all just one category. There's 2 more stories I'm going to hit on with this as well. Let me give you a little context here. So bipartisan group, 38 senators released an open letter on Friday asking Secretary Alex Azar from HHS and CMS Administrator Seema Verma to provide a written plan for permanent changes to Medicare, Medicaid, and Children's Health Insurance Program rules around telehealth. We're hearing from patients and providers who are concerned about when Medicare's temporary changes to telehealth rules will be rolled back and whether they will receive any advance notice, wrote the senators led by Senators Tina Smith, Democrat from Minnesota, and Bill Cassidy, Republican from Louisiana. So patients are anxious about when private payers will change the rates for telehealth services and if they decide to rescind telehealth coverage altogether. They said so. Generally, what you're hearing here is bipartisan support for extending the provisions around telehealth that were afforded to CMS as a result of the president's declaration of a national emergency and CMS using their authority to grant allowances. I think it's allowances or provisions of some kind to really expand the use of telehealth. And there was some rumors going around that essentially those were going to be pulled in some way, shape, or form. And so it caused people to get all angsty. And the reality is that there's a 3-month window. The president has to restate the national emergency every 3 months. So he can't just do it categorically and, hey, we'll end it when we end it. Every 3 months, he has to reinstate that as per the law. And so that's coming up in the middle of July. And so there was some concern that he was going to pull that. So if he pulls that, HHS and CMS lose their ability to just grant those allowances. So that's the big one. The president has to keep that national emergency. And I don't think with two things, I don't think with COVID going back up and that being the minor one, but I don't think in an election year that you're going to see this president or any president for that matter pull something that has this kind of favorability rating amongst the electorate. And so I think people are getting worried about this thing being pulled. Now, granted, there isn't a lot of information around it because it's a mishmash of laws coming together that have allowed CMS to do these provisions. And if it's like a Jenga, right? So if somebody pulls out one of the blocks, then the whole thing sort of falls down. But I don't think there's, I think this what you're seeing is Secretary Azar has been consistent. Administrator Verma has been extremely consistent around telehealth and what she's saying. The president's really on the periphery of this, but what you would say about the president is that he would like to see healthcare disrupted by business, and nothing is more disruptive to the business of healthcare than telehealth. So I'm not sure, even from a direction standpoint, I see this president pulling this. And so I see people getting worked up about this potentially going away. And I'm not sure I see any signs that it's going away. I mean, what's your read on this right now?
Yeah, and I want to say, I can't remember if it was Verma or Azar or somebody else at HHS had tweeted something maybe a week ago, giving an indication that they were absolutely going to extend this for another 90 days. So now I have to go back and look in Twitter to find that.
Yeah, it was
okay.
Somebody underneath Seema Verma, I believe, tweeted out. And where the rumor came from, I called about this and just wanted to talk it through and say, okay, help me understand the laws and how they all fit together. So we talked through, we had a great conversation. But evidently when President Trump was doing the rally in Tulsa, he made some overture on Twitter about maybe not extending the national emergency. I didn't see the overt tweet, but that's essentially where people started to, it's one of those Trump tweets that people were all sitting there going, does this mean this, or does it mean this, or does it mean this?
Yeah, I try not to read his tweets. I mean, it's so conflicting sometimes. Yeah.
So essentially, people were like, "Well, that's what he's saying," and so they came back in and said, "No, we have no intention." So that's the direction it seems to be heading. What I've told people on this show, if you're a regular listener, you know that what I've been saying is, if you're in a health system right now, plan for this to be in place for at least another 6 months. This will be in place through the end of the year, at least the election cycle, but for sure, if not further than that. So especially with Azar and Seema Verma being so adamantly behind it, they've already made provisions through Medicare Advantage to take that bulk of people and make sure that these things are permanent under a provision from the 2018 law that was passed. I think it was 2018. So they've actually taken a quarter of those Medicare patients and made sure that the provisions will continue. So you could see directionally that's where they're going.
I think you're right on this, Jenga part, right? And that there's a lot of stuff in here, reciprocity of licenses across state lines. There's, are you going to pay for a telemedicine visit the same amount that you would pay for a visit when the physician actually touches the patient? A lot of those things are the things that are in this national emergency extension that lets all of this stuff happen. So the best way to do this, in the spirit of never waste a good crisis, is that it seems you do have bipartisan support for telehealth right now. Maybe this is a good time to go in and, sculpt something under really tight conditions that allow this to continue into the future. You and I both saw, health systems go from a few telehealth visits a week to thousands a day in, almost overnight at the beginning of the COVID crisis. It's clear that that's something that patients and families want, something that they like from a consumerization perspective. I think from the healthcare system's perspective, whenever they went into the mode of having to shut down and not do elective surgeries, it was one way they could still see patients and still get payments that they might not have been able to otherwise, or might not have been willing to lean into it otherwise. So I hope Congress does something. I think it would be, this sort of legislation by extension of a national emergency every 90 days or presidential executive order or whatever it turns out to be is not a great way to put a solid foundation under telehealth. So I think we legislate it. That's the best way to go.
Yeah, no, absolutely. Congress is in control of the funding, and they need to take care of that. But here's, if I were the CEO and you were my CIO, what I would say is, hey, stop worrying about this. Focus on what matters. Right. How are we going to use telehealth? What areas where does it make the most sense to expand its use? Do we have a mandate within our health system at this point? Have the physicians, are they really buying into this? Do we need to build a story? Do we have the data? Do we have a new group of champions around telehealth? I'd be looking at the CIO saying, hey, figure these things out. And then, for the most part, don't come to me and say, hey, I'm not sure if this is going to be funded. Let Mari and her team do their job, and you do yours. Get the data, build the story. And in fact, if you want to support Chime, the best way to do that is to give them some data
and help them give them the stories. For sure. And, you look at this, from a long-term perspective, and this is part of the transition from fee-for-service to value-based care, right? We're worried about this and telemedicine, and is it going to survive under this national emergency because we're all using it as fee-for-service. But realistically, looking down the line, as we continue to make a transition to value-based care and take more and more risk, doing telemedicine makes great sense. It's a much less expensive, much less time-consuming way to see patients and make sure they're healthy and that they're staying healthy and staying out of the sick side of the system that costs a lot of money. Use telehealth. It's a digital health program you really should be pushing for, regardless of what the reimbursement model is now, because that model is going to change in the future.
Yeah, so let me hit on a couple of the other stories right now.
Sure.
So the successes and pitfalls of using telehealth for home-based primary care. This is a story out of Healthcare IT News, and it talked about Northwell Health piloted a program in 2018-19 with some funding that they had available. And so Northwell serves a significantly large geography in New York, around the city, Manhattan, Queens, Nassau, Suffolk counties. You get the picture. They had a situation where they're trying to provide home-based care. People could see roughly 6 patients a day because they were doing tons of driving. So they did telehealth. And what they did is that for that first visit, somebody went out, set it up, helped them to do that first visit. And, what they found is, quite frankly, the results were subpar. And it was mostly due to technical difficulties. That was 2018-19. Overall, the video success rate was about 49%. The patients expressed a high degree of satisfaction, but the social workers and the care managers did not. about 23% were not happy with how it went. So they modified it a little bit. And they started, for each of these visits, they sent out the EMS. The EMS agency sent somebody out to the home who could actually troubleshoot and those kind of things. And so they were able to get a much higher success rate that second time around. I know that people in Silicon Valley are listening to this going, what? You're actually sending people out to the home to do a digital encounter? You know, the average age for these people was 88, 89 years old. I can understand why they chose this model. But, you know, the second round, they said, you know, one of the physicians said, I like that I can touch 10 patients instead of 5 in one day, and I can see them on my own rather than relying on somebody else's assessment.
And in their home too, right? In their natural setting, which
so you get
sometimes
that
reveals a lot of stuff. Yeah.
Yeah, absolutely. So, I mean, there are some areas where it works and where it doesn't. That's the first story. And then the second is the Commonwealth Fund did a healthcare IT news again after initial spike. Telehealth visits are on the decline. But that's not the concerning thing. We knew that it was going to come back as offices started opening up. But the reality is, you know, telehealth never went up to fill the void of all the in-person visits, and coming back, the two aren't meshing. So essentially what they're saying is people are still deferring care. They're not doing telehealth, nor are they doing in person. And people are deferring some care that is going to have some significant ramifications long term. So, you know, it's interesting. There's a lot of promise here and there's a lot of opportunity, but we have to look beyond the basic visit to visit. We have to start looking at all the different options that are going to be available to us. You know, we are going to have IoT devices. We're going to have just a bunch of different ways to do this, and it's going to create better models than just this one-to-one as well. We're going to have a care team be able to visit with a patient through telemedicine, and it will be not only much more efficient, but much more comprehensive of a type of care, I believe, moving forward.
Yeah. I think too, you know, that we have sort of wrapped our head around this idea of telemedicine being me using a Zoom-like function to talk to and have discussions with the patient and see what's wrong with them and, you know, treat them that way. There's actually probably a whole broad range of things that fall into that telehealth category. And so it's not just video. It may be, you know, remote monitoring. It could be a lot of other technology that ultimately helps move us down this digital health path.
Yep, absolutely. So I have a story here from a friend of yours. So you interviewed him for the show. It's Arm Yourself, a healthcare CIO's introductory guide to Apple Silicon. Yeah. And Healthcare IT Today, Mitch Parker, CISO, who you interviewed for the show.
Yeah.
And so, you know, for the first time in 15 years, Apple has announced a major architecture change in the Macintosh platform. They used to be, you know, on those Motorola chips, and then they went to Intel-based chips. Now they're going to ARM-based Apple Silicon. So essentially, they're going to be building their own processors to power the iPhones that also power iPhones, iPads, and now they're going to power their computers. Mm-hmm. And, you know, one of the biggest changes, I think, is with Apple Silicon, the iPhone, iPad apps will be able to run natively on the Mac. Mac OS Big Sur also has a control center just like iOS. This convergence of the app support and similar configurations means that the skills used to manage iPhones will transfer over these new devices. So Mitch lays out sort of, you know, this whole thing of don't panic. We've gone through these things before. It's the same, you know, it's the same model. We use MDM. We deprecate the legacy apps. We use virtual desktops. And, you know, we learn a new set of skills and a new set of tools to secure the environment. Have you kept track of this Apple Silicon story at all?
You know, so I've read about it initially, and I think I certainly read Mitch's article about it, and it's, you know, good solid advice from a really good solid CISO. The reality is, I think that as we see this transition happen, there's always going to be a bunch of things that nobody thought about until you're in the middle of it, and then you have that, you know, oh shoot moment where you have a security issue or maybe you have an operations improvement thing that happens that you didn't know until you got out into the middle of that river. So hopefully there's been a lot of thinking that's gone into this, a lot of strong considerations. I'm a Apple ecosystem person, so I think it's really interesting to kind of watch how this is going to unfold. And I think the important part of this is just being agile and keeping your eyes open and thinking about your own organization and how you use Apple's and how you're going to manage this transition and the work associated with monitoring and managing and securing those devices.
This is a classic simplification move, right? I mean, essentially what you're going to end up with is a single OS across all the Apple devices.
Everything's an iPad. Or everything's an iPhone at some point.
Yeah, I never thought I'd be a fan of that, but I can't tell you how many times I'm now picking up my phone to do my banking as opposed to using my computer because the interface is so much better thought out on the phone.
Yeah. There's definitely this situation too today where you have things that you can do on your computer that you can't do on your phone or vice versa. And that can be really aggravating. I have a couple of products that I use to help manage my home, that there are things that I can do on the computer that I can't do on the handheld. And it's frustrating sometimes. And it's not just that. I know there are a lot of apps that sort of have that problem.
This is what I'd like from Epic and Cerner and Meditech and Athena, if they would just sit back and think through, I don't want them to rewrite the entire EHR for the phone. I don't expect that, nor do I want that. Yeah. But I do want them to start to layer interfaces. It's not like JP Morgan and Schwab sat back and rewrote every back-end financial system that they had to make the apps work on the phone. But they thought through certain workflows that were consistent, that happened over and over again. And then they made an interface to get to those things. And I think if they just took a small team, and I wouldn't do anything more than that, a small team over to the side, work off the APIs that they're already providing and say, look, we would like interfaces for these 5 things that clinicians do every day, or these 10 things, and just keep building it out and building it out and building it out. I think that eventually they could rewrite the entire experience on top of, the existing data structure, the existing set of APIs, or at least they should be able to.
I think, when you think about how we should be thinking about these things, this goes back to our telemedicine conversation too. You're not trying to solve world hunger here, right? So telemedicine isn't going to replace all medicine and all treatment that we do, just like this device isn't going to replace all the stuff we do with electronic health records. There will always be things that will say, it just makes more sense to do that on a computer. It's too complicated, or it's too hard to do on a phone. But if you take the things that you think would work on a mobile device and you have a mobile first attitude about your product, and then you prioritize the work that you should do, this is where we get the biggest advantage first. If we do these things on mobile, then you should certainly have a mobile first development flight plan if you're an electronic health record company that says these are the things we're going to put on the phone first and these are the things we're going to put on the phone later, and work through that process. I think you're totally right. I want as many things on my phone as I can because I have it with me all the time, and that's what I use 90% of the time. But there are still things that are just easier to do on my computer, and so those should probably stay there.
Yeah, I mean, I think the so what on this is his statement of don't panic. I mean, we know how to secure things in the environment. Just follow good, sound hygiene procedures. You're going to be fine. All right, next story, 5G. So, 5G. There's a next iteration of the spec, additional power savings. It is kind of a power hog at this point, as all technologies are when they first come out. So there's some power saving stuff in it. Use of unlicensed spectrum, which if you don't know, most cell phones use unlicensed spectrum all the time. It's just part of how they get additional bandwidth and speed. And there's some things around positioning for cars and stuff to get more exact and precise positioning, which you will want if your car is being driven by 5G. And there's some new deployment models. But let's talk about healthcare for a minute, because here's what I've been saying, and I want to bounce this off of somebody else. I've been saying, hey, these specs, these things take time and they evolve over time. And there's really no, I mean, if I were a CIO, I'd be reading these stories. I'd be staying up on the spec. I'd be looking for that point, that inflection point that says, okay, we're ready. We're ready to start thinking about what the deployment model might be and those kind of things. But I still feel like, and this story even goes on, it says, these changes won't be happening overnight or even within a year. It's been almost 3 years since the 5G spec was approved. And though we're starting to see networks and devices take hold, the protocol is far from widespread. It's likely we're years away from seeing the power saving and bandwidth benefits in the real world. So they talk about even the specs we're talking about that just came out, we're not even going to see proliferate for another couple of years. And that's what I'm saying. I'm saying, look, this is probably not something, be aware of it, but it's not something you're working on for another 2 to 3 years, even though I know some health systems are, diving into this deep. I think there's some challenges with diving in deep unless you have a big budget and lots of people.
I think this is if you have a small group of people who are looking over the curvature of the earth at things that are coming as part of your digital health technology, planning program, that's a good thing. And 5G should be something that's in their window. Like everything else that we've talked about today, back to your don't panic kind of strategy on this stuff, I think this is another one of those where you go, it's coming. We don't know exactly what it's going to look like yet. It's getting clearer every day. Fog is being sucked out of the room. We're starting to understand a little bit more about what it will and won't be able to do. And think about, if you're going to consider deploying it, where do you deploy it first, right? So if you think it's an unproven, untested technology and you want to try it out on some things, don't put it in mission critical systems first, right? Find some non-mission critical stuff that you can try it out on first and see how it works and learn how to use it and make your adjustments, and then deploy it to the next level of the organization or to the next level of devices or apps or replacing wired infrastructure or whatever it is that you're going to do. So, I mean, I'm with you. This is like a lot of things. There's a lot of cool stuff that's coming, and don't get wrapped around the axle. Don't bet the farm on some of these things. They're not solid enough yet to say, I'm not going to make investments in wired infrastructure anymore because we're going to 5G. Well, that just isn't a good plan, I don't think.
Yeah. Well, this is going to be one we're going to have to keep an eye on. I'm going to let you, so I'm going to hastily go through the last 4 stories here that I want to hit. This one's in your wheelhouse. So UCSF pays $1.14 million to decrypt files after a ransomware attack. And essentially, the medical school was hit by an opportunistic malware attack on June 1st. And the encrypted data was important to some of the academic work that they pursue as a university serving the public good, officials said. So essentially, they got in, they put malware in, they saw the attack coming, but before they could cut off the attack, they actually, triggered the malware to lock up some of these files, some of the servers, entire servers.
Yeah. The sad thing is we never really hear the post game on this, right? So we don't really know. We never really get the full information on, what happened. Did they not have backups? Were they not patching? What weren't they patching? What was there? Was there a situation with user accounts? Did they have too broad of access? There's tons of stuff that could.
Does anyone hear the backstory eventually? Yeah. I mean, who outside of the people obviously in the IT department at UCSF, is there an agency that would hear the full story? Is there? How would we get the full story so that? Yeah. I mean, I don't want it out in the public. We're not going to share it on this show.
Yeah.
But I mean, there should be forums where these people are sharing this kind of information. Like, hey, here's how they got in. Here's how they attacked. Here's the mistakes we made, and that those best practices sort of proliferate as a result of that.
Yeah, I think you see some of that work now happening through the healthcare ISAC, but a lot of it still. I mean, and maybe rightly so, right? As a cybersecurity interested guy, I'm really thoughtful and careful about any client that I work with actually even talking who the client is, talking about who the client is or anything else, because sometimes that just paints a target on the individual client. Likewise, discussing publicly in detail what has happened to that individual breach might make them more vulnerable in another another attack scenario. So I think the best you can do probably is take that stuff, gather it centrally, talk about the challenges and issues that are, that are kind of anonymous for a larger group of organizations that have been hacked, so that you can take steps toward protecting yourself. Some of it is, and I don't know that HISAC or any of the ISACs sort of keep a tally of, if you only do one thing, it should be patch your computers, right? That's probably where the biggest problem is. And, you hear people talk about that, but I don't know if there's any sort of underlying metrics around that. And that, good general cyber hygiene lists exist all over the place. It's likely that one of those or more of those was the problem at UC.
Yeah. All right. So the next story, I'm just going to do the headline and ask you what you think. So the headline from Healthcare IT News is hasty rush to cloud hosting during COVID-19 crisis could set the stage for a cyber pandemic. In other words, we've all gone to the cloud, and now if they take out a cloud, they could take down several hospitals. I mean, how real of a problem is this?
Generally speaking, I would say that if you use a reputable cloud provider, there's probably a significant amount of redundancy there that in the grand scheme of things, compared to hosting it yourself on your own servers in your own data center, you're probably in a better place. The challenge with that is, in the military, we always talked about a center of gravity. So the center of gravity now has moved, right? So if somebody can successfully take down a cloud provider, they could take down lots of different organizations, not just one, as opposed to, if I was running into my data center, would I be better protected or less protected? And if they attacked me and took me down, I would be an N of one instead of a cloud provider, which might be an N of 1,000. So it could be a much bigger deal. I mean, I think there are a lot of things that happened as we went through this, as we are still going through this first wave of COVID. We bought medical equipment and put it on the network, maybe without all of the stuff that we were supposed to do to make that happen. I think we connected to new suppliers because we were desperate for, PPE and other things. And maybe we did that without hitting all of our gates. Hopefully what happened in healthcare is that, and I have a whole list of those, but hopefully what happened in healthcare is that they kept good track of any place that they made exceptions, and they've gone back and resolved those exceptions to the rule. But I wonder about that because of some of the data I'm starting to see in the Wall of Shame report I referred to earlier. So.
Wall of Shame. So for our listeners, the Wall of Shame is?
So HHS asks healthcare providers to report to them if they have a breach of more than 500 patient IDs, patient information. And that data goes on to, it has an official name, and I can't think of it right now. I just refer to it as the Wall of Shame. If you Google or Bing HHS Wall of Shame, you'll find it. And it basically lists out all the organizations. It talks about the number of, what the breach was about, how many records were compromised, whether it was a hacking incident or a loss of data or something, stolen data or something like that. And it's really interesting because then those are the kinds of things that trigger those inspections that you definitely don't want, those visits from the government that you definitely don't want. So, stay off the Wall of Shame. But there are plenty of people up there, plenty of organizations up there.
And is it still the case that a majority of these are human error?
The answer is it depends on how you define that. So you could even say hacking IT incidents. A lot of those probably were human error, where somebody fat fingered something and left a port open that an organization got attacked through, or they opened an email that they got phished, which then allowed ransomware in. That's human error. And some of these are literally the kinds of things exactly what I think you're thinking of, which is, oh, we put that spreadsheet with 1,000, patients in our research project on what we thought was a common drive, but it turned out that drive was exposed to the internet, and Google crawled that drive, and now that information is available on the internet. So all of those things ultimately kind of come back to
you. What I put in the category of human error? The reality is those ports being open. It's interesting because I had somebody on the show. Who did I have on the show? Nebraska medicine. And we were talking about architecture because I'm horrible with names. I apologize.
That's okay.
We were talking about architecture and how they were looking at utilizing VMware in front of Epic. And the reason they were doing that was because it closed down like a couple hundred ports that were open by funneling it through there. And they just looked at it like, hey, those couple hundred ports all represent an opportunity for somebody to come in that door. And I think that's one of the things we have. We intelligent design, architecture is a thing. We need good architects who are looking at things like, hey, how many ports do we really need to have open? A lot of times what happens is people install the server and just assume, hey, these ports are open because this application
needs it. Yeah.
Needs it. And in reality,
in fact, that's not the case at all. Yeah.
Yeah, you could just shut those things down. So
yeah. A lot of organizations don't have standards designed for, when you build a server, these are all the things you turn off, and then you only turn on the things that are needed. And I mean, we could go into a whole cybersecurity diatribe here, but it's yeah.
Well, but that's one of the reasons I love having you on here. So here's I'll jump to the last story. We're getting close to the end here. So
okay,
major health orgs create National Patient Identifier Coalition, Patient ID now.org. It's interesting, and I've gone off on rants on this before. So if you go to patientidnow.org, and I think the site says it all, because when you go there, it's not an SSL site. So on Chrome, it says not secure, patient ID now. And I think that is
starting right there.
Just sort of says it all. And, at the bottom, it has founding members, AHIMA, Chime, HIMSS, Intermountain, Premier. They all should know better. There should not be a site like this that says not secure, patient ID now with if my brand were on there, I would be embarrassed. Yeah. And you know what? It leads to the problem. And the problem on this is not that a national patient identifier is bad in its intention, but we haven't shown our ability to secure the patient record. We haven't shown our ability to share the patient record effectively. We haven't, we really need to rethink our approach to this. And I will have this debate with anyone who wants to come on the show. The patient should be the carrier of the entire health record by law. They're the only constant at the point of care. They should be given the entire record electronically. And you know what else? If the health system doesn't provide the entire patient record, I think there should be a little button on the app that they push, and it's a direct link to ONC that says, I just visited this health system. They gave me my data. It didn't go into my app correctly. It put stuff in the wrong places, whatever. And, and then they should get fined. We've had about 20 years to get this right, and we haven't done it. And I don't think we deserve another 2 decades, and there's just too much at risk. And we have proven that the patient or an individual can be a good carrier of information from point to point to point. It's very possible to do, and it's probably in my mind, it is the best method to make sure that their health record gets from one location to the next. But anyway,
yeah, man,
that's the National Patient ID. I'm curious. I'll let you have the last word on this, since I went on a rant.
You clearly have an opinion about this, and I don't necessarily think it's wrong, right? I've been kind of yelling from the rooftop since I was a Air Force second lieutenant that we need a single patient ID. We spend way too much time reconciling patient records in our own EHR, not having all the information that we need because we don't get data from other electronic health records or from other health systems or from other sort of odd casual visits that a patient may do to a minute clinic or something like that. So, the data doesn't flow. And I don't know that that's solved with a single patient ID, but I've always felt like having some kind of an ID that you could attach everything to gives you the opportunity to make that happen. I'm with you. I think, Google and Microsoft and others just may have been too early on a personal health record to make it work. It was super complicated. The technology was complicated. How do you get data out from an electronic health record into a personal health record was too complicated. But I think we're maybe at a point where a personal health record could be the right way to go. And not only could you take information from lots of different health systems into your own personal health record, you then have the opportunity as an individual to be able to make decisions about what studies you may want to participate in. And perhaps you could even make a little money on the side by sharing your information with those studies and participating in those studies.
Yeah.
It puts control of your data where it belongs, which is with the patient. And I think that this whole idea requires like walking to the other side of the room and looking at the electronic health record with a completely different view of the world.
Yeah. Well, that's going to be all for this week. Drex, thanks again for coming on the show. 3X Drex, if you haven't signed up, 484848, text Drex to 484848, get signed up. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyric, Sirius Healthcare, and Pro Talent Advisors for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, check out the website, thisweekhealth.com, or the YouTube channel. If you want to support the show, share it with a peer. Please check back. We're going to continue to drop 3 shows a week, Tuesday, Wednesday, and Friday. Thanks for listening. That's all for now.